Great, thank you. Well, good morning, everybody. First, I'd like to thank Norberto and Steve for having organized this great meeting and having invited me to be part of it and being part of the committee. It's really a great honor to be here, and this is my second party in this city, so it's really a very nice thing for me to be present. I'm going to be addressing a topic that is very dear to me and which I think may be one way of getting neurologists and psychiatrists to talk to each other. Because as you know, neurologists and psychiatrists, they don't talk to one another. And when neurologists realize that psychiatric comorbidities may actually have an impact on what they do to treat the seizure disorders, they will pay close attention to these things. Now, this topic is a presentation of certain concepts which is aimed at raising questions. I'm not going to give you the answers. I'm just going to raise questions with the idea of maybe thinking on how to understand the relationship between depression and epilepsy and realizing how complex it is, and thinking of strategies in research that can be implemented both at the clinical level and for you guys who are basic scientists, how you can help us understand this process using animal models. So let's just remind ourselves that psychiatric comorbidities in epilepsy are relatively frequent. And this study from Canada, which is a population-based study, clearly shows that people with epilepsy have a significantly higher lifetime prevalence of psychiatric comorbidities, in particular depression and anxiety disorder, to the point where 1 out of every 3 people with epilepsy, and this is in the general population of people with epilepsy, will at some point in their life experience a depression episode. And most of the time, people who suffer from depressive episodes will experience symptoms of anxiety or comorbid anxiety disorders. So the first thing I want you to start changing your view about depression is that it's not anymore depression alone, but it's a depression-anxiety type of complex that we have to start thinking about. And as you can see in this slide, the depression, the lifetime prevalence rate of 35% is seen in people with both depression and anxiety. Now, for a long time, we were accustomed of thinking that psychiatric comorbidities were the consequence or a complication of the seizure disorder. Most of these data from population-based studies were cross-sectional studies, and it was not until Forsgren and Nystrom decided to look at the temporal relationship between the onset of the psychiatric and epileptic disorders, the relative onset from each other, that they realized that in fact people with epilepsy had already experienced depressive episodes with a significantly greater frequency than the general population. So in their study done in Sweden, people who went on to develop epilepsy had experienced depression 7 times more frequently than controls. And then Dale Hess-Dorfer and Alan Hauser went on and have been the authors that have revolutionized our way of thinking on the relationship between depression and epilepsy, and showed that people with depression have 2 to 4-fold higher risk of developing epilepsy compared to the general population. And this is something that has been replicated in several studies. In people who had had a history of suicide attempt, that risk of developing epilepsy is 5-fold higher. This is one of her latest studies where she compared the incidence rate ratio of depression during the 3 years prior to the onset of the seizure disorder. The seizure disorder is delineated in the line. And so and this is the incidence ratio of people who go on to develop epilepsy compared to controls. So those people who went on to develop epilepsy had 2 to 2.5-fold higher incidence of depression before the onset of epilepsy. And then after the onset of epilepsy, she looked at the population of patients and found that people with epilepsy had also 2.5 to 3-fold higher incidence of epilepsy. So there you see clearly the bidirectional relationship between depression and epilepsy. So depression may precede the onset of epilepsy, and it also can follow the onset of epilepsy. Now, one could say, well, how do you know that the occurrence of epilepsy in people who had a history of depression may not have resulted from the use of psychotropic drugs such as antidepressant medication? After all, we are taught in medical school that antidepressant medications may lower the seizure threshold and cause seizures. Well, this has been refuted by a careful review of the literature that actually shows that, in fact, the people who go on to experience seizures with mood disorders and take antidepressant medications are people who take overdoses. And in this study done at New York University by Ken Alpert, he looked at the incidence of seizures among people who had been randomized to antidepressants of the SSRI family and the SNRI families in studies that were submitted to the Food and Drug Administration of the United States. So he compared the incidence of seizures in all these double-blind, placebo-controlled, multi-center randomized trials that were submitted for licensing in the United States. And what he found is that those people with primary major depression, so these were patients with primary major depression, who were randomized to placebo, had a significantly higher incidence of seizures compared to those people who were randomized to the antidepressant medication. So having been treated with antidepressant medication protected the patient from having seizures. And in fact, people who went on to have seizures with primary major depressive disorders had 19-fold higher frequency of having seizures than the expected incidence of seizures in the general population. So this actually is a nice example which puts into rest, if you will, the concern that the use of antidepressants can cause seizures at therapeutic doses. Now, does depression have an impact on the course of the seizure disorder? And this is data from a couple of studies. The first one is from the United Kingdom, where the group of Martin Brody followed 780 patients with new onset epilepsy for a median period of 79 months. And what he found that, among other variables, a prior psychiatric history was associated with twice the likelihood of developing treatment-resistant epilepsy to pharmacotherapy. So if you had experienced a mood disorder before the onset of the epilepsy, you had twice the likelihood of developing intractable epilepsy. And that was associated with depression particularly. Another study that suggests the same kind of findings comes from Australia. This is a study of 138 patients with new onset epilepsy. And these patients, before being started on pharmacotherapy, were asked to complete an instrument called the ABNAS, which is an instrument that identifies symptoms of depression and anxiety. And as you can see in these Kaplan-Meier curves, in red are patients who denied any symptoms of depression and anxiety. In blue are patients who endorse symptoms of depression and anxiety. And those people who endorse symptoms of depression and anxiety were less likely to be seizure-free at 52 weeks of follow-up. So having symptoms of depression and anxiety before the patients were started on pharmacotherapy was associated with a lower likelihood of being seizure-free after 1 year of pharmacotherapy. Same thing has been found with the response to surgical treatment. This is a study that was done in my previous institutions in Chicago, where we took 100 consecutive patients with anteriotemporal lobectomy. All of the patients had undergone a psychiatric evaluation, and we looked at the seizure frequency at 2 years after surgery, but we had follow-up data up to 8 years. And we asked the question, what was the lifetime history of depression according to the post-surgical seizure outcome? So no seizure, no auras is what we call class 1A, and it's in this column here. So among the people who had no seizures, no auras, only 12% had had a lifetime history of depression, whereas among people who had had persistent seizures after epilepsy surgery, it was 79%. So having a lifetime history of depression was associated with a significantly lower likelihood of becoming completely seizure-free. This data has been replicated by several other studies. This is one of the larger studies from Steffi Stoker in Bielefeld of 378 patients. She was kind enough to lend me her slides, and she's preparing the manuscript for publications. Here you can see the cause of the temporal lobe epilepsy, and 64% were seizure-free, and of those 64%, 43% had no seizures, no auras. And when she looked at the relationship between the previous psychiatric history and seizure outcome, you can see that those people who had no psychiatric history were the ones that had the highest likelihood of becoming seizure-free, no seizures, no aura, or only having auras, whereas people who had depression in the first column had a significantly lower rate of being seizure-free, both not having seizures or disabling seizures or auras, or just having auras. And the worst group was the group who had previous history of psychosis. So these data suggest that if you have a psychiatric history before a temporal lobectomy, the likelihood that you're going to be completely seizure-free is decreased. And if you have a previous psychiatric history, above all a history of depression, the likelihood that you can have that you can achieve complete seizure freedom with pharmacotherapy is also decreased. So how can we explain this phenomenon? And I think the best approach is to look at the neurobiologic pathogenic mechanism of depression and see if those neurobiologic pathogenic mechanisms of depression can be identified also in epilepsy, whereby one could postulate, and these are hypotheses, and I really want to emphasize what I'm going to show from here on are hypotheses that need to be tested in future clinical and basic science research. So we look at endocrine disturbances such as the hypothalamic pituitary adrenal hyperactivity. We look at structural abnormalities of the brain, including hippocampal atrophy, atrophy of frontal lobe cortex. We look at disturbances of neurotransmitters such as serotonin, norepinephrine, glutamate, and GABA, as well as inflammatory processes. And let me touch briefly on each one of these points. So we know that people with major depressive disorders have a hyperactive hypothalamic pituitary adrenal axis, and this has been demonstrated with the use of the dexamethasone suppression test, where you give patient dexamethasone, which normally inhibits the secretion of cortisol, and people with depression, 50% of people with major depressive disorder will not suppress to cortisol and will have higher serum cortisol levels. And this is something that has been known since the 70s, and it's a biological marker of depression, because even in people who have had a history of major depressive disorders and went into remission, that increased secretion of cortisol can be identified. This is a study that is done using cortisol in saliva, in subjects with a history of major depressive disorder that went into remission and controls, but also it's today found in offspring of parents with major depressive disorders. So this is a study where they measure cortisol in daughters of mothers who had a history of major depressive disorder. They had never experienced an episode of depression, and yet they had increased cortisol levels compared to controls. So it looks like a non-suppression to the dexamethasone suppression test is a biological marker of a predisposition to major depression. So in patients with epilepsy, there is evidence that they also are non-suppressors to the dexamethasone suppression test. This is a study that included 16 patients with temporal lobe epilepsy without depression, 16 patients with major depressive disorder without epilepsy, and 16 healthy control. And there was a lack of inhibitory response to the dexamethasone suppression test in both patients with major depression and temporal lobe epilepsy. In animal models of epilepsy, we know that corticosterone can facilitate the kindling process. And this is demonstrated in this nice study by Kumar and collaborators from Australia, where they took rats that were pre-treated before undergoing rapid amygdala kindling with water, corticosterone, and antagonist of the mineralocorticoid and glucocorticoid receptors of corticosterone. And they looked at the number of stimulations that were required to reach the fully kindled state. And as you can see, those rats that were pre-treated with corticosterone require significantly less number of stimulations than the rats that were pre-treated with water, or than rats that were pre-treated with corticosterone and antagonist of corticosterone. So this is a nice example of how corticosterone can facilitate the kindling process. And the question is, could the worsening of seizures that we see in epilepsy and previous history of depression be mediated by hyperactive hypothalamic pituitary adrenal corticoid? Because what happens is that increased corticosterone exposure is associated with damage of hippocampal neurons, and this has been demonstrated in experimental studies in rats and monkeys, particularly CA3 pyramidal neurons mediated by reduction of the dendritic branching and loss of dendritic spines that are included in glutamatherine synaptic inputs. There is, in this cartoon, you can see the loss of the synaptic boutons in animals that were exposed to corticosterone. And there is evidence of decreased levels of BDNF that can be reversed by long-term administration of antidepressants, and interference with neurogenesis of granular cells in the adult hippocampal dentate gyrus. These resulting in structural changes in the dentate gyrus, pyramidal cell layer of the hippocampus, amygdala, and temporal neocortex. So in using these data, one can postulate the hypothesis whether an increase in corticosterone can result in damage of mesiotemporal structures and temporolateral neocortical structures that can then, in the setting of a seizure disorder, make that seizure disorder less responsive to pharmacologic treatment and surgical treatment. What happens in humans with primary mood disorders? Well, what we see is that patients with primary major depressive disorders, when we measure the volume of the hippocampal formations, they actually have a hippocampal atrophy, which is equivalent to 10 to 20% of normal. So this is a study of patients with recurrent major depressive disorders. You have in this column the patients and then controls, and you can see a decrease in the volume of major depressive, of the hippocampal formation of major depressive disorder patients. And the magnitude of the hippocampal atrophy has been correlated with the duration of the seizure disorder. So again, in this set of studies, we see a damaged temporal lobe already in patients with major depressive disorder. Could this damaged temporal lobe facilitate the likelihood of a treatment-resistant epilepsy to pharmacotherapy or surgical treatment? Now, other neuroanatomic and neuropathological changes that are seen in patients with major depressive disorder are atrophy of the cingulate gyrus of the orbitofrontal cortex. We see neuropathologic abnormalities in the rostro-orbitofrontal region with decreased cortical thickness, decreased neuronal sizes, decreased neuronal densities in several layers of that area, both in the orbitofrontal as well in the rostral and as well in the caudal orbitofrontal cortex. And in the cingulate gyrus, we see decreasing glial cell densities and decreasing neuronal size. So we are seeing a neuronal neuropathologic changes in brains of patients with major depressive disorders. Could those changes be accounting for the worse response to pharmacotherapy? Same thing, decreasing the neuronal and glial density in frontal, in dorsolateral prefrontal cortex. And in amygdala, we see decreasing glial cell density. Neuroimaging changes in mesiotemporal lobe epilepsy are magnified in the presence of depression. So let me put this set of data in a proposed hypothesis. So this is a study done in patients with mesiotemporal lobe epilepsy without depression by the group of Lin and collaborators. And what they looked at is at the cortical thickness of the brain outside of mesiotemporal structure. So all of these patients had temporal lobe epilepsy of mesiotemporal origin. And what you can see in red are the areas of the brain with a thinning of the cortex compared to controls. And this was in a group of patients with left mesiotemporal lobe epilepsy and right mesiotemporal lobe epilepsy. And you can see that to begin with, if you have mesiotemporal lobe epilepsy, you already will have thinning of the cortex outside of mesiotemporal structures. So there is damage that goes beyond the amygdala and hippocampus in mesiotemporal lobe epilepsy in this study. Well, the group of Fernando Sendes here in Campinas, he asked the question, we have seen that in patients with primary major depressive disorder, there is decrease in the neuronal cell densities, in the glial cell densities, in the orbitofrontal cortex, as well as in dorsofrontal cortex. And he postulated the hypothesis, is it possible that patients with primary major depressive disorder and epilepsy have a worse structural change of the cortical mantle than patients with temporal lobe epilepsy that could account for a worse response to treatment? And so he looked at the MRI of these patients with using the voxel-based morphometry approach in 96 neurologically healthy adults and 48 people with mesiotemporal lobe epilepsy, of which 24 had temporal lobe epilepsy with depression and 24 patients had temporal lobe epilepsy without depression. And what he found is that the number of areas of gray matter volume loss was higher in patients with mesiotemporal lobe epilepsy and depression. So having depression was associated with a greater number of gray matter volume loss than having just temporal lobe epilepsy. And these are the structures where there was a significant difference in the volume of the structures and the cortical mantle. And as you can see, this happens in mesiotemporal structures bilaterally, in the thalamic nuclei, inferior and superior temporal gyrus, inferior and middle frontal gyrus, middle occipital gyrus, the cuneus and fusiform gyrus, the caudate body, and postcentral gyrus. So one hypothesis to test it, is it possible that patients who undergo a temporal lobe epilepsy and had a prior history of depression are less likely to be seizure-free because there is a more extensive cortical damage that prevents these patients from becoming seizure-free? This is a question that needs to be studied prospectively. I don't know the answer, but I'm throwing these as a challenge to investigate. So one research strategy that we could consider is, first of all, taking patients with new onset epilepsy. So we have to actually do prospective studies using new onset epilepsy patients and giving them a dexamethasone suppression test and measuring volumetric measurements of cortical mantle and mesotemporal structures at baseline, and then follow them and asking, is the presence of hippocampal atrophy, orbitofrontal atrophy, smaller volume of cortical mantles in different structures, or a non-suppression of the dexamethasone suppression test associated with a worse response to pharmacotherapy? Yeah. 3 minutes. Okay. Now, another approach is looking at monoamines. As you know, serotonin and norepinephrine are the neurotransmitters that mediate mood disorders. And what has been found is that patients with major depressive disorder have decreased binding of the serotonin 1A receptor compared to controls. And the same decrease in serotonin binding has been found in temporal lobe epilepsy. So the same changes in serotonin have been identified in both major depressive disorders and temporal lobe epilepsy. And serotonin has been found to play a significant pathogenic role in animal models of epilepsy, with decrease in serotonin secretion being identified in animal models like the Gepper rat, and these changes in PET studies of the serotonin 1A receptor have also been identified in the insula, amygdala, cingulate gyrus, and Raphe nuclei. So again, and what we find is that decrease in serotonin receptor binding, in fact, is under tonic inhibition by glucocorticoid receptor stimulator. So is it possible that the reduction in serotonin 1A receptor binding and mRNA expression in depression may arise secondarily to cortisol hypersecretion? So what I am suggesting is it possible that if we do a prospective study of patients with new onset epilepsy with and without lifetime history of major depressive disorder and get a baseline PET study targeting the serotonin 1A receptor binding and see an association or predictive value of decreased serotonin 1A receptor binding with response to pharmacologic treatment. Now, to finish, glutamate and GABA have been found also to be abnormal in patients with depression, with glutamate being increased in plasma and serum of patients with major depressive disorders. There is increased cortical glutamate in the magnetic resonance studies of patients with primary major depressive disorder. And we are now looking at antidepressant properties of NMDA antagonists. Now, as you know, glutamate is the neurotransmitter by excellence that mediates epileptogenesis. By the same token, decreased GABA has been identified in patients with primary major depressive disorders, and it's been decreased in magnetic resonance spectroscopy studies, as well as in the brain of postmortem studies of patients with mood disorders. And I'm just going to postulate that if we find that there is decreased GABA concentration in frontal lobe structures, particularly in dorsomedial, dorsal, anterolateral, prefrontal regions, and we find increased glutamate in the brain of these patients also in frontal lobe structures, could that combination also account for both the decrease in the inhibitory tone of those brains and the increased hyperexcitability that could then be facilitating the less likelihood of response to pharmacologic treatment and surgical treatment in these patients. And I'm suggesting this research strategy, which would be a prospective study of patients with new onset epilepsy with and without a lifetime history of major depressive disorder, in whom we would do a magnetic resonance spectroscopy study targeting glutamate, glutamine, and GABA, and seeing whether those studies are predictive of a worse response to treatment. And with that, I'm going to stop. Thank you very much for your attention.